over again. All right. Hello, Dr. Dufour. Sinead, nice to have you here. Thank you so much for joining me. I'm excited about today's topic. We're going to be talking about the Mella chair, which I get asked about all the time. And I know that you have done some work in the space of understanding this technology, and I feel like you're always my go-to with regards to research. So before we jump into that topic, I would love for you to just give a quick introduction in terms of how you became a pelvic floor physical therapist and what led you down the path of research as well.
Yeah, great. Thank you so much, Kim, for having me. I'm excited to talk about this. But so I'm an academic clinician. My name's Sinéad Dufour. I share my time between really McMaster University, teaching and doing research, and then my clinical practice, which is the world of my baby. And I mentor a lot of physios. I run my own pelvic health practice out of that perinatal care center. But actually, my PhD and postdoctoral fellowship research really didn't have anything to do with pelvic health. I've been a PT for about 2 decades now, and I was very much in the world of orthopedics and primary healthcare. But then getting pregnant myself with twins and navigating kind of postpartum care and sort of some major gaps in that care. That's what led me to what I'm doing today. So sort of for the last decade, my research, teaching, clinical practice, has all focused on this area. And I am often kind of sort of consulted as an expert in these areas.
Mm-hmm. Amazing. Okay. So let's jump into the Mella chair. So I've seen this, it's talked about a lot on social media all of a sudden. So it was sort of a novel thing for a while, and there was, very few of them, but it seems like there's clinics popping up all over the place with an Mella chair, and I get asked about it all the time. It's also called the Kegel throne, some people refer to it as. So can you tell us, what is the Mella chair?
Yes. So it's essentially an electrotherapeutic modality, right? So essentially it's a chair. So it's set up like a chair, but really it's a medium to put energy into the body, right? So in this case, it's high intensity electromagnetic stimulation. That kind of, there's some coils that are within the chair, and that's what transduces this energy up into the body. So in this case, the individual is sitting with their perineum situated on the chair, and this energy is transferred through the chair up into the perineum to have the intended rehabilitative effect. So in ways, it's not different than other therapeutic, modalities that we've used, electrotherapeutic modalities. Historically in physiotherapy, even in the world of orthopedics, we've used this type of therapy often. And sometimes it's in forms of using sort of electrodes that are sticky that paste right onto the muscular tissue. In the case of pelvic health, the more traditional forms of electric stimulation actually is delivered through probes that are inserted intravaginally or interrectally. So in ways, this is just, a cousin of that type of care.
Okay. And that was a question I had, was like, how similar or different is it compared to the more traditional E-stim, electrical stimulation? And you've just clarified that. And for the one big difference is that this is fully clothed. So you sit on the chair, you're not disrobed in any way. You have all your clothing on, correct?
That's right. So I would say there's probably 2 main differences. One is what you just said. You're sitting fully clothed on the chair. The other is that it is a high intensity, high frequency form of energy, whereas a lot of the more standard probes only are able to produce a lower frequency, lower intensity. So, when you look across the trials, which is something I've done in a research group, we've actually just submitted this systematic scoping review for publication. You see that in the trials that use the more traditional lower frequency EMS, on average, the time of intervention for this type of energy to have the intended effect is about 700 minutes. Whereas when you look at the higher intensity, high frequency types of electrical stimulation, and the Mella, which is referred to as high FEM technology, fits within that umbrella, it's about 180 minutes of intervention. So you can appreciate you're getting a much stronger intervention, so you can kind of get the same effect over a dramatically less amount of time.
Right. Okay. And who would, I mean, there's a lot of people in my world who have incontinence and who have prolapse. I would say those are the two main categories of people who are drawn to the marketing of anything to do with vaginal rejuvenation, pelvic health, exercise, anything. And so they're looking for help. And is there another population, or who else would benefit from this, or is it restricted or most beneficial for that incontinence and prolapse group?
Yeah, so great question. So, looking across the studies, in our scoping review, and we included 40 studies, we have trials that look at this type of stimulation primarily for sort of developing different parameters of fitness capacity in the pelvic floor. But also there's studies that highlight and almost sort of found some of these findings honestly by accident, because most of the target populations for this type of care is sort of for primarily for incontinence, but there's also some for prolapse, and there's some for fecal incontinence too. But many of the studies used outcome measures that also tracked symptoms around sexual pain or overactive bladder urgency frequency. And actually, we see improvements on those outcomes as well. So I would really be saying that for anyone, like always in my care, I'm very much focusing my care on the level 1A evidence strategies, right? Which for the most part is individualized pelvic floor muscle training, lifestyle interventions, bladder retraining, and then in the case of incontinence with exercise, the use of intervaginal continence supports like Uresta. Those are all our level 1A strategies from our most recent clinical practice guidelines. So that is always where I start with people. But in fairness, we also know that those strategies just don't work for everyone for a whole variety of reasons. Even if we look at individualized pelvic floor muscle training and we see that it's 8 times more effective than control for urinary incontinence, right? That's what our most recent Cochrane reviews say. We also know from Dr. Linda McLean's research that still that strategy only actually really helps about 50% of people. And people who have more severe incontinence are less likely to be really cured by just that strategy alone. So it tells us we really need to be well aware and educated of the whole menu of options available, because probably different things are going to work for different people. And so anyone who I'm working with who is having any of those issues that have, a potential indication for this. So as you said, pelvic floor, any type of issue with pelvic floor fitness capacity, right? Issues maybe with urgency or frequency, issues with sexual pain. And they have not really met their goals with the level 1A strategies. That's when I start to introduce them to their options in level 2 strategies, level 3 strategies, etc. And so we know that kind of standard EMS, has been long understood to sort of be level 2B evidence. The scoping review that we just did shows, as I said, kind of higher intensity, higher frequency forms of EMS actually seem to be better because you can get a better effect in a shorter amount of time and have more acceptability because people can kind of keep their clothes on, right? So I will introduce that as one of many options as like a level 2 care option. So again, people who just aren't meeting their goals, particularly from my perspective, if they're just not able to reestablish that fitness capacity of their pelvic floor, they just seem to kind of need help rebooting their system. Electrical therapy seems to be quite helpful. And, a recent 2023 review just on electrical therapy across the board kind of shows that we always thought the mechanism was like hypertrophy and strengthening, but more data is kind of showing the mechanism actually might be around kind of improving an inflammatory sort of profile. So we don't really fully understand the exact mechanisms behind electrical therapy. We just don't. And so it's probably for reasons different than what we actually think why it's helping. But I certainly will make sure people are well aware of it as an option and where it stands in terms of the level of evidence if they are not reaching their goals with the level 1A strategies.
Got it. That makes sense. I've said an answer similar to yours that, look at what the evidence is for first line therapy. And if those aren't working, then this is something to consider. But I wouldn't suggest the Mella chair as somebody's first line of defense per se. So I'm with you so far, which is good. But what does it feel like when you're sitting on that chair? What would somebody feel? What sort of sensations would there be?
Yeah, so this is a great question. And just before I answer the question, I very briefly will say one of my big issues, to be honest with you, about the Mella chair is not what it actually does. It's actually with how it's marketed. And even unfortunately, the manufacturer of this product, which in my opinion actually holds really wonderful rehabilitation capacity, it's just that how it's sold and how it's marketed, in my opinion, is for one, not correct. And for two, almost comes across as predatory. So I think that's honestly why even a lot of my own colleagues in pelvic health physiotherapy really have their back up about it. But what it feels like is it really feels like not unlike, honestly, even what like an interferential current machine might feel like, which a lot of people have used in physiotherapy, or even like a TENS unit. If you can imagine like a TENS unit on and kind of that electrical type of stimulation, but it kind of moves on a varied pattern. So, while you're sitting there and the protocols that have been studied are 28 minutes, you'll kind of feel this kind of variation of different types of tapping and vibration and stimulation kind of going through your body. Which, and again, kind of highlights to you that the way it's sold, like this does 11,000 Kegels in 28 minutes. Well, a Kegel, by correct definition, Dr. Arnold Kegel really made the assumption that, doing this type of exercise was all about strength and creating stiffness, and that's why it worked. And we understand now that that actually isn't quite right. And so a Kegel, from his perspective, was ramping up these muscles to their absolute max and holding them, right? And so that's what a Kegel is. And really, when you're sitting on this chair, that isn't what it's doing. It's putting through energy in a varied, almost taking you through a really varied workout, right? So, it isn't really doing, what it's kind of claiming to do. And it isn't necessarily just like making things stiffer and stiffer and stiffer the way repeated Kegels might do. So yeah, it really feels similar, honestly, to other forms of electrical modalities that people might have experienced. Just the difference is really you're sitting fully clothed, and it goes through kind of more of a variation than what standard models would do, I would say.
Got it. And you've talked about 28 minutes being what you've seen in some of the research, or that's what the general protocols are. And then I think you said 120 minutes total. Was that the amount of time? And so how many treatments and how far apart would people need these is the first part of the question for there to be a potential resolution of symptoms. And then how often would it need to be repeated?
Right. So most of the trials have used a protocol of 6 sessions that are spread across 3 weeks. So 2 28-minute sessions with this energy over 3 weeks. So 6 sessions. There's a couple trials that actually have looked at 10 sessions. But really, when you look at the outcomes really are no better with 10 sessions versus 6. So, it stands to reason why it makes sense that therefore, the recommendation at this point in time with the data we have is 6. And, as far as like, well, how long does it last? I mean, because I kind of consider this one of many rehabilitation tools, how long it lasts is all dependent on, what the beholder is actually doing, right? So if I, for example, am working with someone and I'm saying, hey, so like these are the bladder behaviors you need to do. These are the bowel behaviors you do. This is like your sleeping program that would optimize your biology. And they were good with that for a few months, but then they kind of derailed from that and they were putting totally just different inputs into their system. Well, I would expect that then their health state would change and probably their symptoms would come back, right? So with something
Yeah.
like this, again, if someone is kind of using it really just to help sort of reboot their system and establish maybe a more optimal fitness capacity in their pelvic floor, which is generally how I suggest it's used, my hope always is that people don't ever need it again. That if people have kind of rebooted their system, they've kind of got things on track, they've become more motivated, that they can actually kind of overcome some of the issues they've been having. And alongside, they're doing all the lifestyle things and, all the other things that are actually contributing to their symptoms, and they're doing all that. And then they're starting to engage more in lower extremity exercise more generally. Well, I mean, the pelvic floor is a postural muscle. So, once it's rebooted and automated, really, as long as we're doing lower extremity exercise and we're not sitting and we're getting that kind of force of gravity that comes with standing and walking on a regular basis, we should be able to maintain that, right? We should be good. But also, I mean, life happens, right? You might end up with a bout of bronchitis and that you've been coughing for 2 weeks and you've kind of gone backwards, and people might find, okay, I feel like I need a reboot. My bias is that if someone sort of needs a reboot, I would still rather them have a reboot with sort of a PT or someone knowledge about this area, and then maybe also have a modality like Mella as an adjunct, right? So
Yeah.
your effects on treatment, whether it's Mella or you doing your own exercise program or following, your own walking program, I mean, your effects are only as good as what you're putting in. And I see all modalities, as really hopefully trying to give people like a boost at the beginning. But in my mind, like, I don't love those types of strategies to be kind of used as a Band-Aid and over and over and over again. I'd really rather people kind of doing the level 1A behavioral things, that they're really getting to the root of creating health. That's always my perspective.
Yeah. Yeah. And I agree 100%. Um, I also talk a lot about this being suitable or a really amazing option for people that may have mobility challenges, that may have potentially spinal cord injuries or something that is prohibiting them from being able to connect with their pelvic floor, do that lower extremity work. Has there been any, like, would you agree, I guess, but then has there been any research using populations that may have limitations?
So I would agree conceptually. I would agree with that because we do have lots of data that more traditional pelvic floor muscle training is actually appropriate for those populations. Any of those neural populations, other than like a complete spinal cord injury, but incomplete MS, any of those other ones, we see like good effect of, our more standard pelvic floor muscle training. So in theory, if this is a tool to help sort of stimulate fitness capacity, I would agree with you. Given that I consult with a company called Urospot that uses this technology in conjunction with really amazing physiotherapy care, I know anecdotally that, people who would fall in that basket have gotten improvement from combined physiotherapy and the HiFem technology. But as far as the research goes, like even as I'm thinking of our scoping review, not a single study, not even the ones in our study that was the more traditional form of EMS, actually, was looking at those populations.
Okay. And what about protocols specific to the challenge the person has? So is there a different protocol for stress urinary incontinence? Is there a different protocol for prolapse? Is there a different for overactive bladder or urgency and frequency? Or is it just all standard, the 28 minutes at the proposed frequency twice a week for 3 weeks?
So there are two different established protocols for this tool. One is called Protocol 1, one is called Protocol 2. In the scoping review that we did, the only populations that ever looked at Protocol 2 were for men with erectile dysfunction. And there's very good data of efficacy for this tool for that. For, the myriad of issues among women that we've talked about, all of what's been studied so far is Protocol 1. other than, you have the 6 sessions for the 28 minutes, there is a dial in terms of sort of intensity. And so most of the studies were actually using an intensity of at least 80% of like the max capacity of these machines to sort of get the desired result. So my advice is always, make sure, like, as you're sitting there, it's not feeling so sensitive that the individual who's turned it on for you is saying, oh, well, like, you're only at 40%, because we don't have good data that 6 sessions at 40% are helpful, right? And really, we want to make sure you're getting at least over 80%. And this is why, like, in the collaboration between like the physiotherapists that work with Urospot, the physiotherapists are screening everyone for central sensitization. They're looking at all of these things because they don't want someone who's really highly ramped up and sensitized sitting on this. They can't really tolerate it. Then they're not really going to get the proper treatment effect, right? So it's again why I really see this tool to be used integrated as a modality. I don't really see it as a great tool to be situated in every cosmetic medical clinic on the corner with the message of, oh, just sit down and this will fix all your problems. Like, I really have no patience for that type of an approach.
Right.
Because, to your point, what you just said is a lot of people are ramped up and sensitized. And, they are going to be kind of sitting on there. And then they probably won't be able to tolerate the proper treatment effect. And they don't know the research. And the person administering that to them, has no training. And so it can be a really powerful rehabilitative tool when it is used properly.
Yeah, fair enough. I agree. A couple more questions before we leave, but one thing that comes to mind also is the people who have been told they have a hypertonic or overactive, or my pelvic floor is too tight and therefore I can't do Kegels or standard pelvic floor exercise. I need to work on relaxation. If we look at this, when you were talking about there's a variety of sort of sensations and pulses or frequencies that may happen over that period of time, one of which I would assume would be a relaxation component. So is there a place for the overactive population, the hypertone population, with the MSella as well?
Yes, absolutely. And this comes back to my whole point around when I first started learning about this chair, and this was actually in 2019 at the IUGA conference. There was a number of the big trials were presenting their interim results. And what really caught my attention, and actually the attention of the urogynecologist I work very closely with here in Oakville, named Dr. Carolyn Best, was even though the protocol was targeting incontinence, actually you could see in the outcome measures, people with painful intercourse and overactive bladder all improved on those outcomes. And so really, as a physio, I was thinking, but we would never prescribe repeated Kegels for people with dyspareunia. We would never prescribe repeated Kegels for someone with overactive bladder. So it really got me thinking around, so probably it's not doing these Kegels. And anytime I've talked to the engineering team from BTL, they've never been able to explain to me where they've kind of gotten that. I really think they are, counting every different little blip of energy that kind of pulses through. They're just counting that as a Kegel, and then they're using that as their marketing. So we absolutely do see that, yes, people with those symptoms, or even if I was actually to physically assess someone and someone that is kind of more in that slightly protective state, could benefit. But I'm always making sure those people also are doing all the other things, really from a central factor approach or a peripheral factor approach to address that tissue. So yes, absolutely. I really see the more important thing to be thinking about isn't sort of, oh, am I high tone or low tone? Because we kind of understand now that really trying to think of it that way doesn't necessarily make a lot of sense. I like to kind of get a sense of, are these people really centrally upregulated or centrally sensitized? So
And then what about people from a postpartum, now that's a lot of the population that you work with in the clinic. And when you think of this statistic of, at least what I've seen in the research, is 30% of vaginal childbirths may have a levator avulsion tear or complete avulsion, I guess, but some of them will start to, not the complete, but the partial ones may subside, may ease and sort of heal on their own over time. But is this a population that, some people will say they can't feel their Kegels, or no matter how much pelvic floor exercise and physio they do, they just can't get past a certain level. They don't seem to improve their strength. Is a modality like this, or even the internal probes that we were talking about earlier, is this something that could come in and factor into some potential improvements or support for that population? Yep. And would it be more beneficial? Like, I'm so specific to this population again. Is there any, and there may not be evidence or research on this yet, but is there any indication of how soon after injury we would want to intervene with high fem for there to be maximal effectiveness? Do we have any data on that yet? Right. Hmm. Got it. Yeah. And then just final question. I know that this will be dependent on different clinics, but what is the average cost per session or average cost per sort of bundle of sessions? Yep. Right. Mhm. Okay, cool. Yeah. Yeah. Okay, that's awesome. That's a perfect place to end off. Where can people find you to learn more about your work and potentially come and have therapies with you at the womb? Amazing. And we'll have all those links in the show notes for people as well for easy access. So, Sinead, Dr. Dufour, thank you so much for your time and for your knowledge and expertise. This was super interesting, and I know that it'll benefit everybody who is listening as well. Thank you.